Hello, and thank you so much for joining us today for our continued webinar series of Advantages of Deep Learning in Clinical Cardiac MR Practice. This webinar is brought to you in partnership by GE Healthcare and the SCMR. And today we're so excited to highlight how the power of AIR Recon DL, GE's deep learning algorithm for image reconstruction that delivers sharper images with more SNR and about half the scan time as before. In today's webinar, we'll be discussing how the novel AIR Recon DL has made an impact for their patients in their clinical practice, particularly those that are more challenging and more complicated. But before we get started, I'd like to take a few minutes to review a couple housekeeping tips and helpful hints. At the bottom of your screen, there are a couple of application widgets that you can use. All of these widgets are resizable and movable. You can expand the area or maximize to full screen by clicking the arrows in the top upper right corner. And I'd like to also point out the most important widget on your screen, and that's the chat widget. At any point during this webcast, you can enter in questions, and at the end of the talk, we'll be having a live Q&A session where the panel of experts will be able to answer those questions. And with that, I'm honored to introduce to you our speakers for today. First, Dr. Melanie Atkins from Inova Fairfax Hospital in Fairfax, Virginia, and she'll focus on the comprehensive exams for challenging cardiac patients and how AIR Recon DL has made an impact. And to follow, Dr. Ahmad Al-Jaziri from King Saud bin Abdulaziz University, and he'll discuss the power of AIR Recon DL, particularly for some very interesting and complex MR exams. At the conclusion of both the presentations, Dr. Jonathan Weinsatt of Memorial Sloan Kettering Cancer Center and Weill Cornell Medical College will moderate our panel discussion and live Q&A session that will include questions from you. And as mentioned before, at any time during the webcast, you can enter in those questions in those comments box. And we'll do our best to get to them answered during this session. And without further ado, I'd like to introduce Dr. Melanie Atkins.
Hello, I'm Melanie Atkins, and I'm the Director of Cardiac Imaging at Fairfax Radiology Centers. I'm also the Medical Director of Advanced Cardiac Imaging for the Inova Health System. Thank you for joining me today to discuss cardiac MR and imaging challenging patients. When we think of challenging patients in cardiac MR, the first things that come to mind are cardiac arrhythmias, difficulty breath holding, and our claustrophobic patients. However, I think it's important to also realize that cardiac MR is very challenging for the patient. Our sequences are traditionally long acquisition times, and they require a lot of breath holding. So I believe our goal should really be a full free breathing exam where we have shorter acquisition times, and we're going to have to use single beat options and single shot imaging. In today's talk, we're going to describe both functional and non-functional imaging. Functional imaging is really our mainstay of cardiac imaging. So we're going to discuss gating techniques not only in the normal patient, but also in the arrhythmic and challenging patient. We're going to talk about some new and emerging techniques, which I think is the answer to all of our problems with arrhythmias. And then we're going to finish with non-functional cardiac imaging. When we talk about functional cardiac imaging, we're really referring to our multiphasic acquisitions that allow us to acquire function and flow. And our mainstay is all with retrospective gating. So it's very important to have a good quality EKG signal. So really taking the time to put in on accurate lead placement on our patients with a lot of chest hair to make sure you shave the chest, and evaluating the EKG signal not only outside the bore, but looking at the changes that happen even when you go inside the bore, which are always noticeable even more at 3T. And then consistently following the EKG tracing over time to look for patterns. When we talk about retrospective gating, we are sampling continuously to fill all of the lines in K-space, and we're acquiring images, separate images that represent each phase of the cardiac cycle. We want to minimize any dead time, and after we fill the lines of K-space, the scanner will go back and reconstruct the number of selected phases that we choose. And those numbers of selected phases does not affect the scan time. The scan time is really affected by the heart rate. So this is just a couple things that I wanted to point out regarding retrospective gating. Few very important things about cardiac imaging. We want to make sure that our TR is as short as possible. This help decreases any banding artifacts, and also that our temporal resolution is very rapid. We want to have our temporal resolution less than 45 milliseconds. These are two examples of retrospective gating in a normal sinus rhythm and a patient with sinus tachycardia. And you can see here we have a nice regular rhythm, excellent image quality. This patient on the left has had a prior LAD infarct that we can appreciate both on the short and long axis images. And our patient on the right does have sinus tachycardia, but it is a nice regular rhythm. So let's discuss our patients with arrhythmias. The first thing that we should do when patients have arrhythmias is turn on arrhythmia rejection. This allows us a degree of latitude, and it's the percentage of the R to R interval that's accepted for arrival for the next QRS. And anything outside of that window will be rejected. At our facility, we use 30%, and it's important to note that this can be used with and without a threshold. And with the threshold turned on, what that means is that the scan will abort after a certain number of missed heartbeats. So normally, the missed heartbeats are added on to the end of the scan. So if you have threshold turned on and there's too many missed heartbeats, the scan will abort. The problem with this is that you get no data if the scan aborts. So I recommend that we don't use threshold because some of that data can be useful. So this is an example of how arrhythmia rejection works. On the top is our normal EKG tracing where the QRS is at the expected time. It arrives perfectly when we expect. You can see on the next line, if the QRS is delayed and outside of our 30% arrhythmia rejection window, that beat will be dropped and added on to the end of the acquisition. Similarly, at the bottom, if that QRS is too short and arrives prior to our expected time, that beat will also be excluded. Whereas on the third line, if the QRS complex is in our 30% rejection window, it will be accepted. It's also very important to follow the patterns. Often EKG abnormalities have patterns, certain types of things like AV block. Often PVCs are also come at different types of patterns. There can be respiratory variation. So it's important to have your patient check the EKG tracing at end expiration versus end inspiration. And oftentimes PVCs and these types of things can be less during quiet breathing. I also recommend trying to decrease the scan time to fit into any arrhythmic pattern. So in patients with more arrhythmias, you may only want to try to acquire one slice per breath hold, and then decreasing your parameters to try to make for a faster scan time. This is an example of an 86-year-old female patient with atrial fibrillation utilizing arrhythmia rejection. And although the image quality is not perfect, I think it's excellent in the setting of atrial fibrillation. And it's certainly adequate enough for us to process the function and evaluate the abnormalities. We can see she has tricuspid regurgitation. We can evaluate her wall motion. We can see her nice dilated by left and right atria as well. This is an example of the EKG tracing for this patient. You can see that she has a lot of beat-to-beat variability as we expect in atrial fibrillation. But with arrhythmia rejection, we still have nice image quality. We can evaluate the tricuspid regurgitation and do nice quality function calculation. When arrhythmia rejection combined with pattern recognition fail, the next step is prospective gating. With prospective gating, we are acquiring the images based on a selected percentage of the cardiac cycle between each R to R interval. It utilizes a trigger window, which is like the buffer. And that's the percentage of the R to R interval when the scan stops before the next QRS complex. There are two methods in order to utilize prospective gating. In this example, we've set our trigger window to 20, which means that we are going to scan 80% of the cardiac cycle. You can also utilize a projected heart rate. If you evaluate the EKG and the patient has a relatively stable maximum heart rate, you can put in the projected heart rate and the scanner will calculate the percentage of the cycle for you. With prospective gating, it's very important to keep in mind that you can no longer select the number of reconstructed phases. That will be based on the patient's heart rate, the TR, and the views per segment. So in this example, when we are scanning 80% of the cardiac cycle, when our views per segment are set to 18, we will reconstruct 25 phases. If we decrease our views per segment to 12, we will then get 37 phases. With prospective gating, you can also utilize arrhythmia rejection. However, I don't recommend that because that's probably already failed. So I recommend with prospective gating to try to decrease your scan time as much as possible with decreasing your phase matrix, increasing your views per segment, utilizing acceleration. You have to keep in mind that you will miss a portion of the cardiac cycle, but it still should be adequate for function calculation. And this is an example. You can see it's a little bit jumpy at the end where we've missed a small amount of the cardiac cycle, but certainly this would be adequate for function calculation versus our retrospective gating. When prospective gating fails, our final option is real-time SINE. And this is a non-gated multi-phase SSFP. We want to attempt to speed up the scan time and acquire some qualitative function data. And it's important to keep in mind that the temporal resolution is a function of these factors listed below. So this is an example of a 32-year-old male patient, status post-pulmonic valvuloplasty, who was sent to evaluate his pulmonic regurgitant fraction. On the left, we have prospective gating. Again, you can see that we've missed a small portion of the cardiac cycle. We also acquired short-axis real-time SINE images that gives us some qualitative data about the function. And I think it's important to remember that our flow images, our 4D flow acquisition, will also be affected by any arrhythmias, as we can see here with the image quality in this 4D flow images. But I do think we can still appreciate that we have pulmonic regurgitation, and we would be able to calculate the regurgitant fraction. With real-time SINE, of course, you can attempt to post-process these images. However, you have to keep in mind that there's no true end diastolic and end systolic phase, which is an issue for quantitative function. So this is really more for qualitative assessment. The solution, in my opinion, for all of these challenging patients is DL SINE. So DL SINE utilizes retrospective gating. It can also be free breathing. You can utilize respiratory triggering, or you can also do breath held. This capitalizes on modern parallel imaging techniques as well as utilizes deep learning image reconstruction. And we can acquire an entire short axis stack of the ventricle in a single breath hold, or maybe 2 breath holds. And again, can be free breathing. And for patients with arrhythmia, the 1 heartbeat R to R interval SINE is really the best option. In the example below, we have our short axis stack, and then 2-chamber view, 4-chamber view, and 3-chamber view. And I think you can see really excellent image quality. This is an example of DL SINE. On the top image is standard reconstruction. In the bottom image is our DL Recon, utilizing DL image reconstruction. These images were acquired over 3 R to R intervals, and this entire short axis stack was acquired in 2 breath holds. We could have used respiratory triggering in this case, but we did not. But I think you can appreciate really nice image quality. This is a 61-year-old female patient with atrial fibrillation. On the left, we have our standard short axis SSFP images, which were acquired at 7 22-second breath holds. I think you can appreciate we have very poor image quality secondary not only to the patient's atrial fibrillation, but also she was unable to hold her breath the entire time. Whereas on the image on the right, when we acquire from 1 R to R interval, this entire short axis stack was acquired in 14 heartbeats. And I think we can appreciate the improvement in image quality. This is the EKG tracing of this patient. So we can appreciate she's really in atrial fibrillation, which with a lot of heart rate variability and really nice image quality on her short axis images on the left. When we try to calculate function in this patient, we can see we have a free breathing short axis stack on the left, which is not able to be accurately processed. Again, with her short axis SFP images in the middle with her standard stack, there's so much image degradation from the arrhythmia and the patient's difficulty breath holding that our EF was incorrectly calculated at 40%. Whereas when we do DL Cine, you can see that we have really excellent image quality with an EF of 54%. This is an example of an 85-year-old female patient with worsening shortness of breath. On the top left image, we have our short axis DL Cine image, which we acquired over 1 R to R, 14 heartbeats for the entire short axis stack. On the bottom, you can see our SSFP images. These were 7 19-second breath holds. By the time we got to the HLA images on this patient for 8 19-second breath holds, not only was she unable to hold her breath, the atrial fibrillation and her arrhythmia really affected our image quality. But on the top right, you can see our DL Cine images, which were acquired 1 R to R, have really excellent image quality. Again, along the bottom, we have our single shot phase sensitive MDE, nice nulling of the myocardium. We have our T1 double IR, which was also acquired in a single shot technique. And again, you can appreciate that the arrhythmia also affects the 40 flow images. We can also utilize DL Cine on a 6 R to R acquisition, which affords us higher resolution, which is very excellent for looking at the valves. This is an example of a 91-year-old patient with aortic stenosis. On the left, we acquired our standard SSFP images, and it was a 16-second breath hold per slice. On the right, these are our DL Cine 6 R to R images, and it was 16-second breath hold for the entire stack. I think you can also appreciate that there's improved resolution and with better visualization of the aortic valve leaflets, which allows us to have more accurate calculation of the aortic valve area. And so you can see here, I think we have much better visualization of her degree of aortic stenosis. We can see the valve leaflets much better, and this patient has severe aortic stenosis. For the last couple of minutes, we're going to discuss non-functional imaging, our delayed enhancement imaging, our T2 and edema, as well as black blood imaging. Our non-functional techniques are a type of prospective gating that we acquire the images at a specific point of the cardiac cycle. Most commonly, we utilize mid to late diastole to decrease image blur. These sequences also use a trigger delay, which is the time of detection of the R wave until we start the image acquisition. And we want to utilize single-shot imaging techniques, which utilize deep learning image reconstruction to allow us for improvements in SNR. And these are single beat acquisitions, so we have no challenges with arrhythmia. This is an example of a 76-year-old male with chest pain and shortness of breath. All of the images you see are acquired in a single-shot technique, including the double IR on the top left, our T2 on the top right, and 3 planes of single-shot phase-sensitive MDE along the bottom. We have nice nulling of the myocardium, and we have our circumferential delayed enhancement in this patient with pericarditis. Single-shot phase-sensitive MDE is excellent with deep learning image reconstruction. It's a rapid single-beat acquisition which affords whole ventricle coverage in 1 to 2 breath holds. It can be acquired with free breathing, and we no longer have the issues with low SNR with single-shot technique because of the deep learning image reconstruction, which removes the noise. And in our practice, we acquire these images at 5mm sections, and so we can do rapid 3-plane acquisition in 1 to 2 breath holds, whole ventricle coverage at 5mm sections. This is an example of an 84-year-old female with new onset cardiomyopathy and ventricular tachycardia. You can see on the left that we really struggled with our functional imaging. This patient has a ICD. You can see some susceptibility in the right ventricle, but we really struggled secondary to her arrhythmia as well as difficulty breath holding. The free breathing images along the bottom are also severely limited, but do give us some information about her ventricular function. However, conversely, we have 3 planes of delayed enhancement imaging on the right, where we can appreciate this inferior wall transmural infarct, which could be contributing to some of her episodes of ventricular tachycardia. The next patient is an 88-year-old female with atrial fibrillation, shortness of breath, and inability to breath hold during the exam. And again, we struggled with arrhythmia. You can see our best images are retrospective gating with arrhythmia rejection and a short acquisition time, where we can appreciate the ventricular function, her atrial dilatation, and tricuspid regurgitation. However, our single-shot PSMDE images turned out very nicely with no issues with respiratory motion or arrhythmia. Motion correction techniques have helped improve our perfusion and our T1 mapping sequences and allowed for better, more accurate processing for semi-quantitative perfusion as well as T1 mapping. This is an example of motion correction with T1 mapping. You can see on our image on the right, we've used a modern motion correction algorithm where we have really no motion in the myocardium, which will help us to process the global T1 values much more accurately. Similar story with perfusion. You can see we've acquired this perfusion sequence free breathing on the left with a lot of respiratory motion. And when we apply motion correction techniques, we have really excellent image quality and no respiratory motion. In conclusion, arrhythmias are very common in our cardiac MR patients. We recommend utilization of arrhythmia rejection techniques to address some of these, and then move to prospective gating and other techniques as arrhythmia rejection fails. Pattern recognition is a key element to help with arrhythmias and difficulty with breath holding. With modern imaging techniques, we can acquire a rapid free breathing cardiac MRI examination, where we don't have to worry about some of these arrhythmias and breath holding. DL-Cine, in my opinion, is really the answer to all of our challenging cardiac MR patients. It's an excellent mechanism to address arrhythmias, our issues with breath holding, and can be acquired with respiratory triggering. Single shot techniques are now recommended as we have deep learning image reconstruction to improve our SNR. And motion correction algorithms are also great for mapping and perfusion sequences. Thank you very much.
Thanks, Dr. Atkins. Really great feedback. Now I'd like to turn it over to Dr. Ahmad Al-Jaziri for his talk on advanced cardiac MR with AIR Recon DL.
Good morning, everybody who are watching us in the US, and good evening and good afternoon for the people watching us from around the globe. My name is Ahmad Al-Jaziri, and it gives me a great pleasure to be with you in the next hour or so to discuss the role of cardiac MRI in management of patients, of cardiac patients. And I'd like to thank GE for allowing me the opportunity to share with you some of the recent advances in cardiac MRI and how would they make our journey treating our patient much better. So I'm going to share with you a case that illustrates clearly not only the role of cardiac MRI, but also the idea that better understanding results in a better care for our patients. So Mrs. HD is a 39-year-old female who referred to our hospital for evaluation of heart failure. She presented to a district hospital with NYHA class 4 shortness of breath with orthopnea BNB. Along that, she has lower limb swelling and abdominal swelling. She did not report any history of prior flu-like illness. And unfortunately, she had a very long hospital stay requiring IV medication, because each time they tried to wean her off IV medication, she would relapse with symptoms of volume overload. Her past medical history is significant for type 2 diabetes, hypothyroidism, and bariatric surgery around 10 years prior for morbid obesity. Clinical examination revealed a JVP of 6 centimeters around above the sternal angle. She has bilateral crepitation on chest examination. Her cardiovascular examination showed normal audible first heart sound and second heart sound. There were no added sound and no murmur. Her labs revealed normal blood count and normal kidney function. Her ECG showed sinus rhythm without evidence of prior infarction. She had an echocardiography in our hospital, which showed the same finding in the peripheral hospital with severe left ventricular systolic function with an ejection fraction of less than 25%, with global hypokinesia of the LV, severe right ventricular systolic dysfunction, and fortunately, there was no significant valvular pathology. Upon arrival to our hospital, we wanted to investigate her, the causes of her heart failure. So we did coronary angiogram, as you can see from these three images. She has almost pristine coronary arteries with no evidence of obstruction or atheroma. So, however, being in the hospital, despite giving her adequate therapy with IV diuresis and all the LV enhancing therapy, she continued to suffer from signs and symptoms of low cardiac output and volume overload. And what we have discovered that she had persistently elevated cardiac troponin level at 400 to 650 picogram per milliliter. And I would like to remind our audience that the normal value in our hospital is less than 15.6 picogram per milliliter for females, which again kind of kept us puzzled. Why would a patient with no evidence of any myocarditis or evidence of coronary artery disease remained with elevated cardiac troponin? So the dilemmas that we faced were, why does the patient have a heart failure? And then the second question is, why does the patient have elevated troponin? And based on these findings, we end up again going to the angiography suite and do endomyocardial biopsy, which showed non-specific changes with no evidence of ongoing inflammation. And therefore, we were back to square zero as what to do with this patient and how can we treat her and what is the etiology of her heart failure. Unfortunately, because she remained in our hospital for a long time with symptoms of low cardiac output and volume overload, not responding to medical therapy, the patient was enlisted for cardiac transplant and the workup was initiated. And among the workup was an indication to do cardiac MRI, but there were two questions that was posed to us is, could she tolerate the breath hold being in heart failure? And the second question, what about the image quality if she get tired during the scan? And as you know, most of the time when we reach to the level when we get tissue characterization, it's towards the end of the study. And most of the patients get exhausted with the breath holds, and this may result in poor image quality at the end when we start with tissue characterization, where the real value of cardiac MRI lies in. This is her functional assessment cardiac. These are the cine images which demonstrate her functional assessment. As you can see, we have the short axis images from base to the apex. As you can see, the LV is dilated with a severe global hypokinesis, an ejection fraction that was calculated by volumetric assessment to be 21%. RV has similar features of global dilatation, global hypokinesia, as well as severe left ventricular systolic dysfunction. Likewise, her RA and left atrium, left and right atrium were dilated also. These are the radial images, which demonstrate the same finding that we've seen in the cine images: global hypokinesia, dilation of the left ventricle as well as the right ventricle. And what you can see here, there isn't any regional thinning that may hint us towards an ischemic etiology. This is the wrist perfusion scan, and these three scans actually demonstrate the value of motion correction as well as deep learning in making our life much easier when we interpret images in patients who cannot hold breath, or patients who actually have other factors which show a limited image quality. And as you can see, this is the original image with a lot of motion and I would say acceptable but not perfect image quality. But with the time motion correction and motion compensation, as well as deep learning image reconstruction, you can see here we have a beautiful image that has a huge improvement in the signal to noise ratio, as well as motion, making the interpretation of these images much more easier, and the reader can have confidence in the final interpretation of these images. These are the edema images, and as you can see here, I would say the qualitative assessment of edema did not demonstrate any evidence of edema. We have some issue with a signal to noise ratio that has improved significantly when we apply the new technologies that are available now at the disposal of the imagers, looking at improvement of the image quality. Nonetheless, although the image quality has significantly improved, there was no evidence of qualitative edema on these images. These are the same images looking at the improvement with the deep learning reconstruction that is available at the scanner now, and may help us to have a better image quality and better assessment of our patient. But when we did quantitative assessment of edema by T2 mapping, as you can see, the patient has significant edema, global edema, with a mean value of 88.2 millisecond, and our reference value here is less than 55 millisecond. That with the T1 mapping imaging that showed increased native T1 value of around 1400. Our value is around 960 in our lab, as well as increased ECV of more than of around 50%, while the value is normal value is less than 30%, have clearly demonstrated that this patient has significant ongoing inflammation with increased extracellular volume, increased T2 signal, increased to T1 native T1 value, which clearly indicate a significant ongoing inflammation that can be easily missed with our conventional imaging modality. Coming to the late gadolinium enhancement, these are the initial late gadolinium enhancement images. As you remember, these would have been kind of acquired at the very end of the study, where the patient would be at least for around 35 to 40 minutes inside the scanner with frequent breath holds, and you can see that the images are somewhat grainy, but with the application of deep learning technology, can see that these images are much more crisp and giving a lot of confidence. And when we look at the interpretation of these images, you can clearly see that this lady had subendocardial damage in the subendocardial area of the septum that corresponds to the area of hypoperfusion we see in the wrist scan. There is also some areas of delayed enhancement in the anterior septum in an ischemic distribution, which may hint to a fact that at one stage of her disease, this patient has ischemic injury to her myocardium. So the insights that we have from the CMAR study, number one, that the patient has myocardial infarction without obstructive coronary artery disease. And this is actually an example where which illustrates the significant and pivotal role of cardiac MRI in this subgroup of patients. This is a patient that otherwise would not be started on ischemic medication, given the fact that she has pristine coronary arteries, and therefore she would not have been started in intensive statin therapy, would not have been started in aspirin, knowing that she has no evidence of coronary artery disease. However, after cardiac MRI, it's clearly she had evidence of myocardial injury secondary to ischemic insult, and therefore the patient was started in aspirin and as well as a statin. The other possibility of course, the other causes that may cause this include, number one, thromboembolic, and therefore the patient had a Holter monitor. She did not demonstrate any arrhythmia or atrial fibrillation. She did not have any evidence of intracavitary thrombi that may result in embolic phenomenon. Therefore, we thought that Minuka in her case, was a result of decreased myocardial perfusion secondary to increased left ventricular and diastolic pressure, or probably coronary vasospasm that's common among female in her age. Now, we have also had an explanation of the persistently elevated troponin, which is clearly due to ongoing inflammation, as evident by the quantitative assessment of edema and inflammation that we did in this particular patient. And if you remember, the qualitative conventional image sequences did not show the edema. What about the biopsy finding? Then we may be challenged by the fact that biopsy, which is the gold standard for looking of inflammation, is a negative, and therefore maybe we are overestimating the edema and inflammation in her case. But again, MRI gives us a further insight towards why did this patient had negative biopsy. And the fact is that most of the time biopsy are taken from the right side of the heart going through the venous system, and they are taking from the RV side of the septum. And as you can see, there is a significant area of delayed enhancement that's already fibrosed, and probably that's why the patient did not have any evidence of inflammation. And this is again probably another message that we can take from this case, that sometimes we can do CMR not only to guide where we can take the biopsy, but areas that we can avoid if we have to make sure that we have a sample that is representative of the most of the tissue in the myocardium that may explain the patient presentation. So what we did with this patient, knowing that she has ongoing inflammation, we started an immunosuppressive therapy, IV immunosuppressive therapy, and thankfully, she got much better. We have evidence of clinical improvement. She started responding to diuresis. Her cardiac signs of cardiac output had low cardiac output has improved, and her troponin was trending down. However, therefore, we removed her from the urgent transplant list. We put her on the usual list, and she had a follow-up in advanced heart failure clinic. And the last I heard about her, that her troponin are still very low to negligible, and she's doing extremely well on medical therapy after we have shifted her from IV immunosuppression to oral immunosuppression. So in conclusion, this case illustrates the pivotal role of cardiac MRI in evaluation of patients with heart failure and cardiomyopathy in general, not only to assess the status of the disease by giving accurate assessment of ejection fraction and volumes of both right ventricle and left ventricle. And as we know, cardiac MRI is the gold standard for evaluation of volume of ventricular volumes and ejection fraction, but also to look into the etiology of heart failure and find our other concomitant diseases that are present in each of the cases. New CMR tools, particularly the deep learning, motion correction, and quantitative assessment are now available, and they significantly improve the diagnostic yield of cardiac MRI. And then deep learning is likely to change the way we practice CMR. Now, we may take a patient that probably cannot breath hold, and hopefully by doing so, by utilizing deep learning, get measures that are representative and diagnostic and may help us identify what is the problem in our patient. And finally, I will quote this quote from Galileo, which said, "All truths are easy to understand once they are discovered. The point is to discover them." And I do believe that with the recent advances of cardiac MRI, there are many truths to be discovered in patients with heart failure. And I'm sure with the artificial intelligence and deep learning, this journey of discovery will be much enjoyable than before. And with that, I thank you for your time and looking forward to the discussion part of this webinar. Thank you.
Thank you, Dr. Al-Jaziri, for the great talk and very exciting cases that you showed. And now at this point, I'd like to welcome Dr. Weinstaff, as he will be moderating the panel discussion from the audience. And again, you can use the Q&A section at the bottom of the screen to ask any questions.
Thanks so much, Heidi, and thanks so much to the audience for joining us. Thanks as well to Dr. Atkins and Dr. Al-Jaziri for really fantastic talks on both your parts in terms of highlighting the utility of cardiac MRI, as well as the additive value of AIR Recon DL. A couple of general questions, then I'm going to turn to audience questions, which are helpful as well. First, maybe for Dr. Jaziri or Dr. Atkins, in terms of input, you know, you've shown some great examples of additive value of the utility of AIR Recon DL in terms of clinical cases. Are you using this selectively in terms of your patients, or is the AIR Recon DL approach the default in terms of your cardiac MRI applications on your scanner?
I'm happy to go ahead and start. At our facility for delayed enhancement, it's now the default. We're using single shot phase sensitive MDE for all patients in 3 planes. It's also the default for our T1 and T2 imaging at this time. And we are doing research with DL Cine, evaluating 1R to R, 3R to R, and then some high resolution valvular sequences. And those, as soon as we're able to use them, that will probably be our default as well. We're in the process of identifying the best and most efficient way to use that, whether it's with breath holding, utilizing respiratory triggering, et cetera. But I do think that will come into play in our routine cardiac exam in the near future.
Dr. Al-Jazeeri?
Yeah, unfortunately, we don't have the facility as fully available in our centers. We use it only for selective cases. But as Dr. Atkins said, probably it will be the way to go. I think, as you can see, the amount of information that we get there, the clarity, the confidence in the decision-making about the case imaging is so huge to be ignored. So I think it will be the way to go.
That's great. A couple of additive questions that I'm just going to bring in. In terms of Dr. Atkins, great talk with regard to arrhythmia rejection. 2 questions for you. The first, similar to my first question, how are you defining arrhythmia? You obviously, for patients with atrial fibrillation, we find the arrhythmia rejection and more specifically prospective gating to be incredibly helpful. We've also had cases in which we'll selectively turn it on after the patient gets into the scanner. Obviously, a patient may not have an arrhythmia when they start, but you put them into the scanner and there can be irregularity and otherwise. So how do you thread that needle in terms of things?
So I have exactly the same experience. We tend to start with arrhythmia rejection at 30%. We have a fairly high volume of elderly patients, high percentage of atrial fibrillation, and certainly we run into arrhythmias very frequently. And so we tend to have arrhythmia rejection on at 30% in most cases. I also am really blessed to have an excellent number of cardiac techs who are really well trained and been doing cardiac MR, some of them for longer than I have actually. And so I think having those technologists who have a good understanding of constantly following the patient's EKG throughout the entire study, because we do see that things tend to change as the patient gets tired and they've been breath holding, for once they get over about 30 minutes, we start to see image quality degradation if we're doing a lot of breath held sequences, which is why I'm trying to move to as many free breathing options, more rapid acquisitions, so that we can really get that rapid cardiac MR exam. But otherwise, the same as you, we start with arrhythmia rejection almost very quickly. We don't, sit there and watch challenges without using something. So we tend to start with that very quickly in the scan, and then we'll move to prospective if need be. And I think that's a minority of the time. We tend to be really good with shortening acquisition times and using arrhythmia rejection. And then I hope DL Cine is really going to replace all of that in the near future.
That's great. I'm going to move to a couple of questions on late gadolinium enhancement that we've gotten from the audience. I'm going to give a commentary as well. The first question from a member of the audience regarding LGE, when it comes to free breathing approaches, is your preferred approach that being single shot, or do you favor three-dimensional navigator imaging? How do you approach free breathing LGE, and what's your preferred pulse sequence in terms of diagnostic assessment?
I can go ahead and answer that. For our facility, we tend to use single shot phase sensitive MDE in all of those patients. The newest iteration of that can actually be utilized with navigation, so you can also apply that. But we tend to, just because of the rapid acquisition and now with AIR Recon DL applied to it, we used to have an SNR problem. We no longer have that now that we can apply AIR Recon DL. So that's really our go-to for all of those situations.
Dr. Ziri?
Yeah, for our facility, we do single shot. And another comment I would like to say also about patients with atrial fibrillation, it's the slower the heart rate, the better sometimes. And people usually get very anxious in the beginning of the exam because, unfortunately, the people talk about it and you will go into that tube and you will be very hard to breathe. And the patient get very anxious in the beginning, but once they settle down and they get used to the scanner, the heart rate can settle down. And arrhythmia rejection works very well. But for the delayed enhancement, single shot is the way to go, at least in our center.
I agree. So, we touched upon this, and I'm going to take this as well. People have raised the issue, sometimes talk about in clinical practice, the issue of subtle enhancement. Patients sometimes with hypertrophic cardiomyopathy or even myocarditis, and there'll be very small or subtle regions of patchy enhancement. The question was, what is your experience in terms of how to recognize it and differentiate it from artifact? And I would just obviously it's one of experience and otherwise, but I would also point out the issue that one of both of you brought up in terms of SNR and really the importance of signal to noise ratio in terms of making that distinction. And we found in our site that we image both at 1.5 and 3 Tesla. Certainly in terms of the newer iteration GE scanners, the image quality and the SNR offered at 3 Tesla is really transformative versus prior iterations. And that the AIR Recon DL reconstruction algorithm and software algorithm and hardware really has boosted SNR in terms of our late gadolinium enhancement images and as well as our parametric mapping. But let me ask your questions, you panelists as well.
So I agree with everything you just said. If we were sitting here a couple of years ago, I would have had a completely different answer. But now that AIR Recon DL is integrated into single shot imaging, we're the same. We acquire both 1.5 and 3T. I think it's important to do, now that this is a very rapid acquisition, I do think it's important to do 3 planes. And I think if you see something on one plane and not the other 2, I usually tend to call those artifact. I think it's important, to evaluate in 3 dimensions. But I agree with you. I think the application of AIR Recon DL to single shot phase sensitive MDE has made a real difference in SNR, and to the point where we use it really across the board at this point.
Yeah.
So
Dr. are you having consistent results? Because you really presented some beautiful parametric mapping images. Are you getting, we certainly are at our site getting consistent results, both with T1 and T2 mapping. But what is your opinion in terms of using non-motion corrected versus motion corrected results? How do you make that distinction in terms of your site?
So I think it's very important to remember that each time the heart moves, we are putting the blood pool into the area of interest. So the motion correction is extremely important, and that little change may change the whole picture. Now, just as the audience know, pericardium, let's look at the pericardium, whether the pericardium is affected or not. A little motion here and there can move the pericardium completely out of the area of interest, and that would lose a lot of information. So I think the more help we can get in this, the better we are, and the more confident we are in our assessment. And as Dr. Atkins eloquently alluded to, what we thought previously that artifact may not be actually artifact nowadays, because when we look at the spectrum of the disease, we don't look at the disease in one time, but we look at the spectrum, and each time there is a progression and there is regression and there is a prognostic value of each of these segments. So I do believe that having motion correction is crucial, because it will definitely enhance my confidence in writing that statement at the end of my conclusion.
Sure, absolutely. Related to that, and I'm going to put this to Dr. Atkins as well, maybe get your experience. At our site, we are using parametric mapping in virtually all exams, because we believe that it intrinsically helps us with diagnoses, and that there are certainly a fair number of cases in which you go into the exam with one diagnosis, but you might leave the exam with another. For example, a patient with an acute myocardial infarction, and it turns out the patient has myocarditis, and so you wanted that T2 map, after the fact. And so why raise it to question? So we're including parametric mapping in virtually all exams, except in patients who are severely limited in their ability to tolerate. At your site, how important is cardio maps at present in supporting both the cardiologist and radiologist in terms of exam interpretation?
So we do always, if we have the chance, we do it. And I have another example that wasn't there, but that was a very interesting lady with an abnormal part of her anterior septum that keep on growing with no other abnormality. We did everything possible, and we did a couple of exams. And the question was from the referring cardiologist, are we putting patient in an anxiety, telling her that she has an abnormality? Could this be normal? Mm-hmm. And of course, over a serial of exam, we did not figure out what's going on, because each time we do it, there was no delayed enhancement, no qualitative edema, but that abnormal configuration in the septum is there. And when we did the parametric mapping, it showed clearly that that area is abnormal. And at least we can tell the patient, although it is abnormal, this may not carry a higher risk for you, but this is something that we should follow. So I do believe that each time we have an ability, like your center, each time we have the time and the mean of doing it, and the patient is cooperative, I think it should be integrated as an integral part. And maybe soon it will be actually the standard of examination rather than the add-on information. What do you think, Dr. Atkins?
I agree. We're doing it in pretty much across the board in all patients, acquiring both T1 and T2 mapping, T1 mapping pre and post as well. It's a fairly rapid, it doesn't take a lot of time added to the scan. We occasionally won't do it if a patient's really struggling in the magnet, but it's in virtually all of our protocols at this point.
A couple of technical questions in the time we have left. Dr. Atkins, with your functional images, are you routinely using asset adjunctively with your image acquisition?
Yes, we are.
You are. And related to that, to put you on the spot, just out of interest, general matrix size that you're using for either 1.5 or 3T?
Well, I have to go back and look at all of our at exactly what our protocols are. I probably have it actually, and that I can look it up. But and I'm happy to share them. I'm happy to share them.
In terms of your breath hold times for a given Cine exam with DL, can you give me an estimate of what you're achieving?
So for the SSFPs or for DLC?
Yeah. For SSFP.
So for standard SSFPs, we try to acquire 2 slices per breath hold, and they're usually range from 17 to 20 second breath holds for 2 slices. When you use
and DLC, when I add in DL, now you've got 70 and 20, and now let's contrast that with DL.
So that's 70 to 20 for 2 slices. So if you think about a short axis stack is usually somewhere 14 slices. Yeah. You can usually that will be 2. You can do the entire 14 slices in 2 breath holds, and they're usually less than the per slice breath hold. So for instance, I think in a couple of the examples, they were around 14 to 16 second breath holds and either one or two of those. So it's less than somewhere in the 20-second range, depending. Now, if you do one R to R, you get the entire stack in however many heartbeats it is, right? It makes perfect sense. So if it's 14 slices, it's 14 heartbeats. And then depending on when you do 3 R to R, it depends on how many slices you're doing and how you shrimp your breath holds basically to try to make them. Usually for those, our 3 R to Rs are 2 breath holds around 14 seconds, 15 seconds.
That's fantastic. And that's our experience as well, that it's transformative in terms of what it can provide.
It's a major difference, no comparison.
Yeah, absolutely. We've also had experience, and I think that Dr. Ahmad showed some cases which demonstrate that not only does it enhance general image quality, but we've had cases with ring artifact in which the DL algorithm is successful in removing that ring artifact and really
correct.
Is that your experience as well?
Yeah, so if you think about the way the AIR Recon DL actually works, so it's applied at the raw data filter level, or at the raw data level. So if you think about traditional image reconstruction, conventional image reconstruction, we add in all of those raw data filters that actually give us those Gibbs artifacts, right? The ringing and all of that. And so that actually comes from the conventional image reconstruction. So when you utilize AIR Recon DL, that is at the raw data level before you've applied any of those raw data filters. So you no longer have those, a lot of Gibbs and ringing artifacts those come in actually from those raw data filters. So the AIR Recon DL is before you've actually applied that. So that is a correct statement. You don't see those Gibbs or ringing artifacts any longer because the AIR Recon DL is before you've applied any of that. So that's that is my experience as well. And that's the purpose of it, was to apply it at that level to try to get rid of that. And so all of that noise is actually removed from the image, which helps us, tremendously with our SNR.
Yeah, no, that's my experience as well. We talked a lot, and we have very limited time left. We talked a lot about functional imaging. We talked a fair amount about tissue characterization. Dr. Jaziri gave great examples in terms of late gadolinium enhancement, parametric mapping, really powerful in terms of how it transforms clinical care. Final comments in the time we have left in terms of utilization for phase velocity encoded imaging and otherwise. So I'll turn that to the audience and to the panelists to get your experience and maybe comments as well.
So I alluded to it a couple of times that arrhythmias affect flow as well, and they truly do. And that's one of the challenges we're working on with 4D flow. We're a big 4D flow facility in my practice, and we try to use it across the board. But it's an issue with arrhythmias, right? It's affected just like your other functional issues, and that's something we're working through. And you have to keep that in mind in these patients with severe arrhythmias, if especially in your congenital heart disease and things like that, where the 4D flow is what you're holding your hat on for the diagnosis and all of that. I think it's something that's really important to keep in mind, and we have some work to do, in my opinion.
Yes, I would agree. Thank you both. I'm just looking for audience or for panel commentary. I think we're really at our time limit, so I'm going to turn it over to Heidi.
Great, thank you. Again, I think that you all could have had more time to just keep going with discussions, and it was really great today. I'd like to thank our special guests, Dr. Melanie Atkins, Dr. Ahmad Al-Jaziri, and Dr. Jonathan Weinsapp, and to you for joining us today. Just as a reminder, the on-demand version of this webcast will be available to you on the SCMR online section at the scmr.org website. At this point, this concludes our webinar. Thank you again for joining.